thank you to everybody that has dialed in today for our webinar series collaboration with BD Life Sciences Diagnostics. This is a pre-recorded session from Series 1 just due to some technical issues that we did have when we ran this webinar last week. So this is Series 1, Best Practice in Blood Collection, and I have here with me today Ellie De Leon. So Ellie, I'll get you to say hi.
Hi everyone. Hello.
So guys, Ellie's fantastic. I will go into this a little bit more in a minute, but Ellie and I have teamed up together to bring you a bit of a pre-analytical series. There's at least 7 to 8 different series that we're going to run a few weeks apart, and I will jump into those details for you in a second. So firstly, just to do acknowledgement to country, and just wanting to say that New South Wales Health Pathology acknowledges the traditional custodians of the lands on which we work and pay our respects to ancestors and elders past, present and emerging. I'm coming to you today from Wiradjuri country, and I am a proud Wiradjuri woman. And Ellie, where are you today?
I'm proud to say, Amy, that I come from Daru country, which is sits at the base of the Nepean Blue Mountains. Yep.
Fantastic. Alrighty, so introducing Ellie to you guys. So this is Ellie De Leon. So as I've said, Ellie works for BD, and she is like me. She is a nurse by trade. Ellie has over 25 years of experience in the nursing profession, and a lot of that is in ICU, and she brings with her a wealth of knowledge and a wealth of stories. She spent the last 11 years with BD and is doing some fantastic work in that space, and I've had the pleasure of working with Ellie over about the past... Oh, it's been a little while now, Ellie, hasn't it? It's been a good couple of years. But if you've been lucky enough to sit in one of Ellie's workshops on venipuncture, then you know it's well worth it. Ellie, have you got anything to add?
No, thank you for those very kind words. Thank you, Amy.
No, not a problem. And then, guys, for those of you who don't know me, my name's Amy, so also a nurse by trade. I guess you'd say where my specialty lies is in more of the rural and remote space. I love emergency nursing, and I've been sitting in education for about the last 5 years before I came over to New South Wales Health Pathology Point of Care as their clinical training coordinator. So just going through a little bit of a plan that Ellie and I concocted for a bit of a series and a collaboration together, because we do recognise that you guys are sitting in facilities where you quite often are taking your pathology and doing collections for the laboratory, but you're also doing collections for point of care testing. So whether you're working on our smaller devices like the iStat to our larger analyzers like the ABLs and the GEMS, it's kind of going hand in hand, and there is a lot of things to be taught in that space that overlap, and a lot of pre-analytical things that we can touch on. So Ellie and I thought that a fantastic opportunity to put all this together for you. So you are sitting in Series 1 today, where we're just going to go over, I guess, the basics. It is really a fundamental session that we have today. It's some of you might even find that it's a bit just, I guess, simple and basic, but today really is about setting the fundamentals, and then we really do get into the nitty-gritty of things as the series go on. So today we just focus on specimen quality, the phases of testing, what the lab and point of care tests, and just some common pre-analytical errors. Then we'll get into Series 2, which we will have a focus on hemolysis, which is a really big deal in the point of care and the laboratory space. Series 3, Ellie's got some fantastic stuff to run you through on the order of draw, the effects of not following your order of draw, We'll also talk about fill volumes in both point of care and laboratory spaces, sample mixing and correct techniques, and all things that can contribute to pre-analytical error. Series 4, we chat about the importance of patient identification, mislabeling, things like that. And I hear Ellie's got a great case study for that one to share with you all. Series 5, we recognise the more, I guess, predominant capillary testing is becoming in our hospitals. So we wanted to dedicate a series to capillary collections and having a chat about quality collections, what they look like, things to consider. We actually bleed that into Series 6, where we'll talk a little bit more about some skills and some little tips and tricks that could help you with capillary collection. And then finally for this series, well, this is where we're up to at this point, but Ellie and I could be bringing you more, never say never. But Series 7, we will also chat about sepsis. We'll talk about things like the importance of lactate on your point of care devices. Ellie will chat through blood culture collection and best practice in that space. So there's a lot of details here, but we're really excited about it. So we might just jump straight into it. And Ellie, I'm going to hand over to you if you'd like.
Okay, thank you, Amy. Yep, so as I said, hello everybody. My name's Ellie Gillian. I'm one of the clinical nurse consultants from BD, and I'll be joining you live with these webinar series. So our first series, let's kick this off, Amy. So if you could go to the next slide. So specimen quality, okay, so phlebotomy is the most common invasive medical procedure in healthcare. We use that as the #1 diagnostic tool. Besides MRIs, X-rays, CT scans and ultrasounds, we need blood. So at the end of the day, 70 to 85% of those clinical decisions are based upon the information derived from the laboratory test results. So it's uttermost important that we do adhere to your hospital's policy and procedures to ensure that the blood is collected in a manner that preserves the integrity of the specimen. So what I mean by that is that at that point, at that time, you stab your patient with a blood collection needle, or whether it be collecting blood from a freshly inserted cannula or accessing any of your central venous access devices. We want the best in vivo sample. So whatever it represents is in your patient's blood, at the end of the day, is exactly what the lab will receive in the tube. But a lot of things can happen along the way. The collection method can lead to a lot of erroneous test results, and which means those results won't be accurate. At the end of the day, they can have adverse patient outcomes. So, for example, if we get wrong diagnosis, wrong treatment, and wrong treatment potentially can equal death. Next slide, Amy. So let's talk about the phases of the laboratory testing. So basically, this can be divided into 3 phases: pre-analytical, analytical, and post-analytical. But pre-analytical is where, how do we as clinicians, whether it be doctors, nurses, phlebotomists, or whoever is collecting the blood, how do we get the blood into the blood tube before that tube hits the lab? Okay, so that's a pre-analytical phase. The analytical phase is basically when the tube hits specimen reception and gets punched into the computer, and the technicians and the lab staff start to analyze the results on the machines or the instrument. And then the post-analytical is, what do we do with those test results? But if you look at my pie graph, it is amazingly to see that 68% of the laboratory errors occur in the pre-analytical phase. So let's look at that a little bit closer. So next slide. Thanks, Amy. So in the pre-analytical phase, numerous errors can occur prior to the specimen arriving in the lab. So the number of healthcare professionals involved in the blood collection process may present more opportunity for errors to occur. The pre-analytical errors can impact, as I said, on patient care, resulting in unnecessary investigations, inappropriate treatment, and increased length of stay. And you may go, oh, well, but at the end of the day, increased length of stay means increasing your health dollars for your facility, and everyone is responsible. So that's why it's of uttermost importance to get the best in vivo sample at that point, at that time. You collect the blood from your patient so that we can assist to send quality samples back to the lab and assist in the reduction of the pre-analytical errors that occur. Next slide, thanks, Amy. So just some fun facts about blood and what we test at the back end of the lab. So basically, blood can be divided into 3 separate groups. So when we're looking at your whole blood, so your whole blood specimens is when we collect blood tests using either your purple or your pink EDTA blood tubes, okay? So we're looking at a whole blood specimen, anything like your HB, your full blood count, your white blood cells, red blood cells, leukocytes, etc. The scientists in hematology and blood bank need a whole blood specimen. And then your samples can be divided either into a plasma or a serum sample. So when we talk about a plasma sample, these are the ones that you collect in either your blue sodium citrate tube, which is normally used for coags and INRs and APTTs, or if your facility use either the green or the dark green lip HEP tubes, okay? They're looking at plasma specimens, versus a serum specimen is any samples that are either collected in your gold top or your red top, okay? But at the end of the day, what you need to understand is that the difference between a plasma and a serum specimen is that the plasma specimen still contain all the clotting factors inside, versus a serum sample has no clotting factors present. And it all depends on which lab you or what LHD and what your lab prefer, either plasma or serum specimen when it comes to the biochemistry family. So it's always very important to check with your policy and procedures in regards to what blood tests go into what tube. Thanks, Amy. Next slide. So there are different types of blood tubes in your facility, and the reason why that is that each particular tube contains different additives. Either they make the blood clot or they prevent the blood from clotting, and either we need a serum sample or a plasma sample. So these are just the most common ones that you probably see in your facility. As I mentioned before, your blue sodium citrate tube is normally done for all your coagulation studies, like your INRs and your APTTs, and that's looking at a plasma sample. Then we move into your biochemistry family. So your biochemistry family can be divided into serum sample versus a plasma sample, and your serum samples are anything collected, as I mentioned to you before, in a gold or a red top. But in these particular tubes, they have a clot activator inside. So that clot activator makes the blood clot down the bottom, producing a beautiful serum sample. Then we have your light green or your dark green tube. Either they have either plasma with gel or plasma with no gel, and inside these particular tubes have the additive lip HEP, and that prevents the blood from clotting. And then we can move on to your hematology family. So as I said before, your hematology family consists of a purple or a pink. And generally in your purple EDTA tube is generally, your HBs and full blood counts are done on this. And then your pink is normally for your group and whole cross match for transfusion purposes, but it also depends to what facility or which hospital you work at. Say, for example, at RPA Hospital, They don't actually use the pink for a group and whole cross match. They use a large 9mm purple for the group and whole cross match. So it's vitally important that you ensure that you actually get the right tests in the right blood tube. Thanks, Amy. Next slide. So then, what are the common pre-analytical errors associated with specimen rejection? So why would the lab reject your sample? So I definitely know the lab never ever want to reject your sample, but unfortunately they have to reject your sample because they will lead to erroneous results. So these 5 bullet points I will cover in more intensity in series 2, but the main reasons why the lab would reject your sample is if the sample is hemolyzed. If it's too hemolyzed, the results will be erroneous. If the specimen's contaminated because we haven't followed the correct order of draw, or you haven't given the lab the sufficient blood sample. Say, for example, in your blue citrate tube, you will know that you need to give the lab 2.7 ml of blood, okay, in that particular tube. Otherwise, you get the incorrect blood to additive ratio, or simply the sample may be clotted, and if it's clotted and it's got platelet clumps or microclots and things as such, typically, you know, seen in our EDTA purple or our pink tube, normally the lab will need to reject it. Or number one big error is misidentification and mislabeling. So they are the most common pre-analytical errors is why the lab will reject your sample. But as I mentioned, we will cover these more intently in the following series, and I think I will now pass it over to Amy to cover off the point of care side of things to you.
Perfect. Awesome. Thanks heaps for that, Elle. So yeah, so my side of things is more just to take us into the point of care. But what's really fantastic about this is I do feel like Ellie did a lot of the work for me, because a lot of the stuff that she has spoke about from the laboratory side, we can actually translate now into point of care, and we do see a lot of the same issues that I'm going to touch on now. But the first thing I do like to touch on, and a little bit of a significant difference, is that when it comes to point of care and we start to compare the point of care results with our laboratory lab results, we do, when they don't match or they don't, something looks a bit wrong, we often hear things said such as the machine is broken, the machine needs calibrating, the cartridges that we are using are faulty, the results cannot be trusted, and that point of care is nowhere near as accurate as the lab. When really the cold hard truth of the matter is that in point of care, around 70 to 80% of the errors that are caused on point of care devices, they are pre-analytical. And what Ellie has already touched on is that pre-analytical is the procedures that take place before analysis. And I often say to my colleagues, I'm like, pretty much it's the stuff that we do wrong in our collection space and our handling of our sample that has contributed to that erroneous result. The other thing that I really like to, I guess, talk to people about and get them to understand and give food for thought to is the fact that in point of care, we don't have the safety net of the laboratory. And so what I mean by that is that if we handle a sample incorrectly or we take a really poor collection, maybe the patient was really difficult to bleed and it was just a really hard sample to obtain, if we send that to the lab, we at least know that the lab are going to call us up if something's really wrong with that sample. They're going to reject it and say, hey, sorry, you're going to need to collect a fresh sample. There is no luxury of that in point of care. There is no lab that's going to ring us up and tell us if the results are erroneous. So we need to be able to identify when we may have contributed to those erroneous results and subsequently ended up with an incorrect result. Because if we don't, That's a huge patient safety risk because we can potentially go and treat a patient on that incorrect result, and we've seen it happen. So just something to think about is the fact that, yeah, the lab's not going to be there for us as our little safety net if something's gone wrong with our collection and our handling, and we really need to be able to identify that and to be able to fix that in the point of care space. So in point of care, what we test, I could be here all day. Point of care is huge, and depending on where you're coming from, you might have one device or you might have about 5 in your facility. But for today, I'm just going to focus on our devices that test our whole blood samples. And predominantly, wherever you're watching this from, you could be using an ABL, a GEM, or our handheld devices such as the iStat. So, like I said, there are plenty more than that, but these are the ones we're going to focus on today. So it'll be our syringe-based devices, our ones that use whole blood. And I think the big thing to remember here is that when you're testing in point of care and you're testing whole blood on our devices, we always need you to be using a point of care pre-heparinized syringe. We steer clear of plain syringes, and we'll go more into that in other series as well. But you'll see in the little picture there, I have included just some different styles of the pre-heparinized syringe that are floating around throughout the state. You might also be working on one that's not here in this picture. But yeah, in my hand there is just 3 common syringes that are heparinized that we're seeing used on the devices. And our testing can range from everything from your gases, your lactate, your electrolytes, metabolites, co-oximetry, troponin, and the list again just continues to grow in point of care. Pre-analytical errors. So I got pretty lucky here. I was all but able to just copy and paste Ellie's slide for this one, because the pre-analytical errors on her side of things, what she sees in the laboratory space, we see in point of care as well. So hemolysis is huge for us, and we will chat a lot more about that in series 2. Specimen contamination, insufficient sample volume, clotting. I have added in insufficient mixing because we are seeing an insufficiently mixed sample in our syringe contributing to erroneous results. And misidentification and mislabeling is also big for us as well. So this is what we will be touching on in the next series and the following series that we've got coming. But just to I guess to go into it a tiny little bit more before we wind up today is labelling. It is really easy to get blasé in point of care testing to not label your point of care syringe, and if I'm being honest, I have been guilty of it in the past myself. You collect your sample from your patient, you walk to your machine to run your sample, and you think to yourself, hey, no one else is going to run another sample in the next 5 minutes, so I'll be fine. You walk away, you come back, and then suddenly 2 syringes have appeared, and then you realise, crap, like I'm not sure which one is mine because I didn't label it. And yeah, it can be a big issue in point of care, and we are seeing it more and more. Underfilling of our syringes. Not a lot of people are aware that there is a lot of importance placed on how much blood you collect into your point of care pre-heparinized syringe. The mentality is that these devices only take a very small amount of blood, so people think they only have to collect a small amount of blood. But what ends up happening is if you don't collect enough, you end up with way too much heparin in too small of a sample size, and this really does impact our results. Every syringe is different, and we will chat more about this in other series, but just as a take home from today, a general rule of thumb is we tell people to work on around about half of the syringe that you size of the syringe that you're using. If you're working on a 2 mil, we need you to be collecting around about 1 mil. If you're working on a 3 mil, we're looking about that 1.5, 1.6 mil. But we will touch more on that in the following series. Mixing is huge for us. We just want to make sure that we get that heparin nice and thoroughly mixed through our sample. When we don't, we do become a little bit susceptible to things such as microclot, which our devices are really sensitive to. Clotting is another one that's really sensitive. I guess our devices are really sensitive, I should say, to microclot. And our biggest culprit in point of care is the collection into plain syringes. Even if you collect into a plain syringe and then you decant into our point of care heparinized syringes within 30 seconds, which doesn't seem like much time, unfortunately it's been enough time for microclot to form. And again, the devices pick up these microclots and have a really hard time analysing results and can produce erroneous results. Hemolysis, we've dedicated an entire series to next in a few weeks, so we won't touch too much on that, but point of care, we do see a lot of issues with hemolysis, and they affect some pretty important results, and unfortunately we have seen patients treated on these erroneous results. So it's going to be a really significant series that we go into, and we've got some great case studies for you in a few weeks. And the last one for us in point of care, contamination. The biggest contributor to contamination that I'm seeing lately in the point of care space is people accidentally drawing drugs or Hartmann's or normal saline or certain sorts of solutions into their point of care syringe from lines. Usually comes from just forgetting to do draw and discards and things like that. But I do have a really good case study when we get to that series. So what's next in series 2? Ellie and I have got a lot of things to talk about in the lab space and point of care space in terms of hemolysis, why it is such a problem, the mechanism of interference, analytes affected by hemolysis, and some troubleshooting during blood collection. So some tips and tricks and things that you guys can do to limit your chances of hemolysis, how to identify it, particularly in point of care, and all that sort of thing. So in the meantime, if you're watching this recording and you do have a question that you want to ask Ellie or myself, or you want to reach out and see if you can get some more education for your facility, our details can be found here. And Ellie and I are more than happy to help out any way that we can. Ellie, anything to add before we wrap it up today?
No, that's the end of series 1. So as I said, very open at the moment due to COVID. Happy to support everyone virtually, and then once COVID and the doors are open, you'll get to see our friendly faces face to face. So thank you, Amy, for today.
No, perfect, and thanks for helping out, Ellie. It's been great working with you.